Thank you. Thank you for the opportunity to talk about this. And thank you, Agnieszka, for the really excellent talk as well, setting the stage uh, for this. So I'm going to be talking in particular about sickle cell disease, which is a single gene disorder. And while we've developed some treatments here for the vessel occlusion that results from this abnormal hemoglobin that polymerizes in red cells, what we're really after is fixing this single gene defect through either hematopoietic stem cell transplantation or gene therapy. And this shows the current and future treatments for sickle cell disease. Drug treatments are largely based on increasing the time between deoxygenation polymerization so that cells can get through the circulation before polymerization and occlusion occurs. But just like for Fanconi anemia, we have both allogeneic transplantation and autologous gene therapy that we're working on. Eventually, of course, we'd like to get to number 4 here, in vivo gene therapy. So in treating adults with sickle cell disease, we first contemplated allogeneic transplantation with a matched sibling donor. Most individuals don't have a donor within the family, but for those that did, we still had the further limitation, excuse me, that most adults with sickle cell disease have end organ damage, making them ineligible to undergo a conventional transplant. So we developed a chemotherapy-free low-dose TBI-based regimen with Campath sirolimus. And so on graphene in 9 of the first 10, no further sickle-related events, no graft versus host disease. But all patients remained on immunosuppression. So we extended this to 30 patients where we made rules for weaning immunosuppression if at 1 year they had full donor erythroid cells, so all red cells from donor, and no graft versus host disease. And we were able to wean the majority of patients, over 80%, with this strategy. And we recently looked at the experience at our center at Chicago in Saudi Arabia with our host for this session, Dr. Al-Zharani, and confirmed in a much larger number of patients, 122 patients, that this approach could produce robust engraftment without graft versus host disease. We also looked back in a retrospective cohort study from 90 US centers reporting to the CIBMTR and found about 1,000 patients that had been transplanted between 2008 and 2017, for which we had at least 3 years of follow-up. And we found that, of course, the results are best if you're less than 12, less than or equal to 12, and have an HLA matched sibling, HLA matched sibling being shown here, overall survival and event-free survival in blue. But alternative donors, including haploidentical transplants, are producing curves that are beginning to get close to what we see with a matched sibling. And this was before we had a few tweaks in the haplo protocol, including, just increasing the irradiation dose from 200 to 400 from the Hopkins group, where, the vast majority now graft with this approach. So that allowed us to ask how much correction is needed to fix the disease. We had patients that we'd been following myeloid chimerism, which tracks with erythroid chimerism, for years, and we had 3 patients who experienced declining donor myeloid chimerism levels after prolonged follow-up. And they all had sickle trait donors and had their hemoglobin S fraction go above 50% when their myeloid chimerism dropped below 20%. And with Courtney Fitzhugh and Stefan Cordes, a mathematician slash hematologist at the NIH, we came up with a mathematical model to determine if it was just differences in lifespan of red cells that explained this observation. So he made a prediction based only on red cell lifespan. And you can see in red the data from the patients, and in blue the predicted data from this mathematical model, taking only into account lifespan. So that tells us that because the lifespan of normal red cells so far exceed those of sickle, we only need 20% when sickle cell disease is the only complication. Now, if they have other genetic changes that prolong or shorten the half-life, that could be different. So then we asked, can we do this, with viral vectors with the patient's own cells? And when Michel Sadelain and then later Philippe Labouche showed that HIV-1 would allow for therapeutic gene transfer for the hemoglobinopathies with the beta globin gene and the complex regulatory elements that we need to have high-level expression of this gene in hematopoietic stem cells, we could move now from basic to translational to the clinic. And we did this in the non-human primate model, which is our preclinical model for testing these approaches. But unfortunately, these old world monkeys are resistant to HIV infection and to also transduction from HIV-based vectors. So we had to figure out what was the limiting factor. It turns out this is TRIM5-alpha, which targets the capsid of HIV when there's a species mismatch for degradation. So in the non-human primate, when you use HIV-1, this gets targeted for degradation. But there's a similar virus, a simian immunodeficiency virus, from which we could use the capsid, and we wouldn't have this recognition of the species mismatch. So just by using a part of the simian immunodeficiency virus in our viral vectors, we could then begin to comprehensively test HIV-1 based vectors in this model. And here you can see with this simian immunodeficiency virus, 30% of cells expressing GFP, for example, in this competitive repopulation assay versus only a few percent from the standard HIV-1 based vector. So this is now over the 20% using only half of the graft, and that allowed us to then begin to think about globin vectors in this model. And here you can see one of the things that we did was to try and improve titer of globin vectors by putting them in the forward orientation. You can see about a 10-fold increase in titer with the forward orientation and a further 10-fold increase in transduction efficiency with these vectors compared to the reverse-oriented traditional vectors, now above the 20% mark that we need to make this work in humans. So we launched a study with our industry colleagues, Bluebird Bio, the HTB-206 study to look at HIV-based gene therapy for sickle cell disease. And this protocol went through a couple of changes. First, switching from original to improved transduction methods, to requiring transfusions beforehand to settle the bone marrow down, and then finally moving to plerixafor mobilized peripheral blood as the HSC source, as we showed in some background studies that this was a better way to get HSCs. This has recently been published, and I'll show you some of the data that we didn't get into the publication. First is that in Group A, while we had a decent vector copy number of 0.1, meaning that on average, 10% of cells have one copy of the vector, this is lower than the 20% that we need, but it was stable long term. In Group C, with the changes, we have a vector copy number as a median of 1.5 copies per diploid genome. And again, it's stable out now to 3 years. And here you can see the difference in T87Q hemoglobin that's encoded by the vector in red. So that's quantitated by HPLC. About 10% of the hemoglobin by HPLC is coming from vector. And we got about a gram bump in hemoglobin to around 9 or 10 in these subjects. Whereas in Group C, we had almost half of the hemoglobin coming from T87Q, and we had a normalization of the hemoglobin to 11 to 13. We also looked at integration site analysis to see where these vectors landed, to see the complexity of hematopoiesis that came from there. This is normally how it's represented, the top 10 represented in colors, and then all the rest shaded in gray. So you can get a sense of the total number by seeing what the top 10 do. These were done by Manfred Schmidt, the late Manfred Schmidt, in his company in Germany. And this provides us a unique fingerprint of all of the progeny of those cells that we transduced ex vivo and can be used to track them if any clonal expansion occurs. So here you can see Group A versus Group C. Right away, you can see a much higher fraction by the top 10 in Group A than in Group C. And also here, the median number of unique integration sites about 10-fold higher in group C at about 20,000. The median unique integration site number also correlated with vector copy number. So the higher the unique integration sites, the higher the vector copy number. Also, the higher the unique integration sites, the higher the expression of the transgene that we put in the T87Q. Patients had resolution of severe vaso-occlusive events, which are shown here in blue in the 2 years prior to informed consent. And in yellow after, so no severe VOEs after gene therapy. And this is very similar to what we see after allogeneic transplantation. Actually, in our older patients, in our allogeneic experience, it takes a little longer for their pain to go away. So in the first year, we're still seeing some vaso-occlusive events that patients are calling vaso-occlusive events. They feel just like the pain of their sickle cell disease. It takes about a year for it to go away in the allogeneic transplant setting. We had a safety signal, and that's really what I'm here to talk about. We had a patient develop MDS AML 3 years out. We wondered if this was vector related, and we looked at the blast and didn't find vectors. So we knew in this case it wasn't vector related. But we had a second patient a year ago develop AML 5 years out, and in this case, there was vector found in the AML blasts. The vector was integrated in the gene VAMP4, which doesn't have any role in cellular proliferation or oncogenesis, but we did a pretty comprehensive analysis. I'll show you some of those data to try and see if vector was driver or passenger. Both patients incidentally had what looked like secondary AML with driver mutations in RUNX1 and PTPN11 and also monosomy 7. But we determined criteria first to say whether vector was causative, and then we devised the experiments to answer these questions, like are there classical drivers, no substantial changing gene expression, vector not active in the blast, transcriptional profile similar to other known secondary AMLs, integration site found in others, unremarkable with respect to cancer and not disrupting genomic elements. These would all say vector is passenger. So this is where the vector integrated in exon 5 of VAMP4 and chromosome 1, and this is not a coding region, so it didn't disrupt the coding region. We looked at expression either in chromosome 1 or around the integration at VAMP4 and didn't see any gross changes in vector expression, although we did, of course, in chromosome 7 where there was monosomy 7. We found this gene to be a common integration among patients treated both in the sickle cell trial and in the thalassemia trial, and none of these other patients had any contribution of an integration site in this gene VAMP4 greater than 0.05%. So, because there was monosomy 7, loss of 11p, RUNX1, and PTPN11 mutations, no changes in expression around the gene, low level detection of expression in the blasts, all of these other things consistent with known AML drivers, we determined that the vector was a passenger, not a driver in this AML. But something is driving this, because we had 2 patients now among 43 developing AML post-gene therapy. And so we look back across our experience in the matched and haplotransplant setting and in the CIBMTR analysis that I showed you, and you can see we're finding similar percentages with different stem cell transplant regimens and different donor sources in this disease, sickle cell disease, whereas we have it among the 63 patients treated with the same vector in the case of thalassemia. So there's something about the disease and the transplant that appears to be contributing to this overall risk of MDS, AML, and sickle cell patients. In 2 of the patients in the haplo trial, among 3, for which 2 were found to have a TP53 mutation in their blasts, Courtney Fitzhugh went back to pre-transplant samples and found cells harboring this identical mutation at very low frequency before the transplant. So this said that in at least these two patients, these clones existed prior to transplant, and after rejection of the transplant, I think, it just gave some advantage to these cells to proliferate and then transform. This has been seen in other settings. So patients with CHIP before autotransplant for lymphoma have a much higher frequency of treatment-related myeloid neoplasm, 14% versus only 4.3 without CHIP clonal hematopoiesis before transplant. This is even seen in patients getting chemotherapy for ovarian cancer. So we think that of the things that we can change to reduce the risk of AML, MDS-AML in these patients, that much of that has been done in the course of this, getting higher transduction efficiency, getting much higher number of clones contributing, resolving the disease, so there's not this continued stress, hematopoiesis, and inflammation, all can mitigate this risk of MDS AML. So getting it right, getting the patient better, we think will be helpful in mitigating this risk. And so we've done a lot in the last a decade or so to improve on our genetic strategies for modifying hematopoietic stem cells. But as you heard in the last talk, we haven't done much for conditioning. And so building upon the work of Agnieszka before, we were supported by a bedside grant to develop this antibody drug conjugate mediated conditioning in the non-human primate with Magenta Therapeutics and with Dave Skadden at the Harvard Stem Cell Institute. And as she mentioned, this is a way of really targeting hematopoietic stem cells by directly killing them through a payload that's potent for killing of quiescent and dividing cells. And this gives us an opportunity, as she mentioned, to develop a less toxic conditioning regimen. So again, c-KIT, because it's present on hematopoietic stem and progenitor cells, this is Agnieszka's work showing that a single dose of this ADC can completely deplete HSCs and allow for robust engraftment. And this is the isotype ADC. So really no killing, no engraftment practically with this. We developed an ADC that's potent for killing both human and non-human primate CD34 cells with a similar IC50. And we performed a dose escalation study with an in vivo selection strategy. So just tell you a little bit about this in vivo selection strategy. There are EPO receptor truncations that are associated with benign autosomal dominant erythrocytosis, made famous by this Olympic cross-country skier who medaled across 4 Olympics, 7 Olympic medals. He had a hemoglobin of about 21 because he had a truncated EPO receptor. And in this case, erythropoiesis remains EPO dependent, but just leaves you at a higher hemoglobin. And this could potentially allow for selection of gene-modified cells if we co-express this truncated EPO receptor with a therapeutic vector. So what we did was to co-express this with a smear to BCL11A, which will reactivate fetal hemoglobin. We tested different promoters and a vector that doesn't have this truncated EPO receptor. And here you can see the smear by itself with 2 different promoters gives us a little bit of fetal hemoglobin in the mice, in the marrow of these mice at 6 months of about 5%. But the anchorin promoter smear with the truncated EPO receptor gives us about 40% fetal hemoglobin. And so we took this into the monkey model with either 0.3 or 0.4 milligrams per kilogram of the ADC and compared it directly with animals that got a multi-dose busulfan regimen that's ablative, 5.5 milligrams per kilogram. So this is pharmacokinetically modified dosing for the non-human primate. And here you can see transient suppression of neutrophils in the 0.3 and the 0.4 treated animals is very similar to what we see with busulfan. And this is hemoglobin F induction confirmed by HPLC in these animals. In the first animal at 0.3, we saw a little fetal hemoglobin that dropped off, but higher in the second animal. In the 0.4 milligram treated animals, we saw equivalent fetal hemoglobin to those animals treated with busulfan. So I can summarize here and say that clinical trials have established that we can cure this disease now with allogeneic bone marrow transplantation. Matched sibling, you can pretty much count on greater than 90% chance of cure. With a half-matched bone marrow transplant, we're seeing results now that are approaching that of an HLA-matched BMT, but it's a little more difficult to pull this off. You certainly need more in the way of immunosuppression to get these grafts in from a half-matched donor. Gene therapy trials are now accruing. We've demonstrated that with gene addition, you can get what looks like a cure of this disease, very similar to what we get with an allo transplant. And I haven't had time to show it, but we've seen now with editing, even editing at the BCL11A erythroid enhancer, we can get similar kinds of improvement in hemoglobin and resolution of pain, hopefully with these non-toxic conditioning regimens that you've heard now about. We should be able to expand access to these potentially curative strategies. And really what we need for the places where this disease is more common is an in vivo strategy where we can deliver these types of therapies straight to the bone marrow. So I'll stop here and recognize the collaborators there, including again the chair of this session, along with the members of my group, former member Dr. Khaled Asawi, who's back now in Saudi, starting his own career there.